So hello to everyone and welcome to this M80 Alliance webinar on this important topic today related to Afghanistan, done in cooperation with Emergency and CRIMEDIM. Emergency is an independent and neutral international organization founded in 1994 to provide free, high-quality medical and surgical care to victims of war, landmines, and poverty. CRIMEDIM is a university-wide academic center that conducts research, education, and training in the field of disaster medicine and humanitarian health. You will hear more about this organization from the speakers in a few minutes. My name is Luciano Saso. I'm a professor of pharmacy and medicine at the Sapienza University of Rome, and I'm a member of the executive committee of the M80 Alliance. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at the annual event in Berlin, at regional meetings, and the more specific expert meetings. Since the tragic COVID period started, we organized several webinars, and this is one of them after actually the 3 years that we started this series. More information is available on a dedicated page on the Migrant and Refugee Health section of the M80 Alliance. For this meeting, I would like to thank very much Francesca Bocchini and Rossella Miccio. Rossella Miccio is the president of Emergency, and she will chair the webinar today. And also would like to thank very much all the distinguished speakers who accepted our invitation. Rossella holds a postgraduate degree in peace building and conflict resolution from Uppsala University in Sweden, and she has been president of Emergency since 2017. Always driven by the principle of free and high-quality healthcare for all, Rossella has played a pivotal role developing the organization's projects around the world, and in particular in Afghanistan, Sudan, and Uganda. Rossella leads emergency involvement in global events like the Paris Peace Forum and World Innovation Summit for Health, and movements such as the People's Vaccines Alliance and the European Citizens Initiative's Right to Cure. For this organization, I would also like to thank very much the World Health Summit team in Berlin, in particular Julian Kickbusch, Friederike Sontag, and Luisa Jordan. And I would like to really wish to all of you a very pleasant and fruitful meeting. Thank you, Rossella, and please, you have the screen.
Thank you very much, Luciano, and for this introduction and a very warm welcome to our distinguished speakers and to all the people that, despite the technical problems, managed to join us today. It's a real pleasure for Emergency to share this webinar on how to improve access to care in Afghanistan. This is an issue that is very close to our heart because Emergency has been working in Afghanistan since 1999 and is currently running 4 hospitals and over 40 clinics in 11 different provinces in the country. And this is basically the reason why we thought that it was important after 2021 to, let's say, use our widespread presence in the country, our network, to give voice to the people of Afghanistan and to go a bit more deeper into what the health needs were after the Taliban took over, and particularly what was the system offering in terms of access to healthcare, which were the major barriers for Afghan citizens to make sure that their right to a proper healthcare was granted. So this analysis that was developed with the CRIMEDIM revolved around a comparison between before and after the change of the ruling powers in Afghanistan. And we would like also to have this the findings of this report and some of the recommendations to be shared as much as possible, as we are doing it today, because we would like to keep Afghanistan high on the global agenda, as the international community is kind of disengaging from a country that still hosts more than 35 million people. So I would, this was the rationale that was behind the decision to start investigating the health access in Afghanistan. And as Luciana was saying, this project was carried on together with Grenadier University, particularly the training, the disaster medicine and global health within the University of Eastern Piedmont in Novara, where the first speaker, Martina Valente, is a research fellow with a PhD in global health. Martina also obtained the, I don't know how to pronounce it, but Vrije Universiteit Amsterdam, with experience in qualitative, quantitative and mixed method research in the fields of global health and humanitarian medicine. So Martina, I would leave the floor to you to briefly give us an idea about the key results of the research and how it was carried on. Thank you very much.
Sure, thank you so much. So can you see the screen?
Yes, we do.
Yes, so thank you, Rossella. Yes, I'm very happy to present our project about access to care in Afghanistan. The context of the project has been already described, so I will directly jump to the objective of our study. Actually, we wanted to understand and to achieve a thorough understanding of access to care in Afghanistan, and we wanted to explore specifically trends, barriers, and changes after August 2021. As was said, and as we all know, in August 2021, there has been the change of government in the country. Besides being a change of government, this modification brought with it several parallel other changes. So on the one hand, there was the end of the conflict, end of fighting in many areas of the country, and many areas actually that were considered battlefields were reopened for the not only for citizens, but also for researchers and humanitarian health workers. However, there were also other changes, perhaps negative ones, such as brain drain in the country, the freezing of international assets. Many humanitarian organizations left the country, which fueled economic and humanitarian crisis. So if we knew that all these changes had caused changes in the lives of many Afghans, we were still unsure whether these also resulted in modifications in access to care. So this was the standpoint of this project. A few words about the methodology. We decided to conduct a mixed method study, and it was divided in 3 different phases. First of all, we descriptively analyzed health records collected by emergency clinics in the country. As we all know, there's a network of hospitals and first aid posts and primary care centers from emergency in the country, and we relied on those data. We also disseminated a questionnaire to patients and caregivers that were visiting emergency premises. And we also conducted semi-structured interviews with healthcare professionals, which were both members of emergency staff as well as directors of provincial and national hospitals. This was the outreach of the study. We managed to reach 10 provinces out of the 11 where emergency operates, which were quite densely populated. As you can see, approximately 37% of the national population. We managed to obtain back 1,803 valid questionnaires in different provinces, as well as to conduct 43 interviews. This was our understanding of access to care. Since we were aware it's a very broad concept, we decided to integrate 2 frameworks, 2 conceptualizations of access to care. We were both interested in patients-related factors influencing access to care, such as their ability to reach, their ability to pay, as well as health system-related factors, such as the availability of services, the affordability of services, and so on. Also considering the 3 delays that patients go through when approaching healthcare facilities. And this understanding of access to care was at the foundation of the development of data collection tools and data analysis and interpretation. But then I would like to spend some more minutes on the results, and I will provide just the most relevant and interesting results from all our 3 different phases. Then I encourage those who are interested to consult the report that has been published online on the emergency website. So initially, I'd like to start with some of the most interesting results about our analysis of data. This graph reports the adult admissions for surgical operations due to war-related injuries, as you can see, bullet, shell, mine, and stab wounds. And it was very interesting for us to see that there has been quite a significant drop in admissions in August 2021. This drop being particularly significant for Lashkargah. Lashkargah is located in the Helmand province, which is one of the provinces that has seen the most drastic decrease in active fighting. And it was very interesting to see that really the data and the results are confirming this changing pattern of fighting in the country. And it's even more interesting to look at these graphs against each other, because these other depicts the non-war related surgical admissions. In this case are pediatric admissions. And as you can see, there is quite a sharp peak of admissions also in once again in Lashkargah. And this is because, also confirmed by the interviews, this is because on the one hand of an increased mobility in the country, which had led to an increase in road traffic accidents, as well as other civilian trauma. And on the other, we can see also this peak because the hospital in Lashkargah actually managed to change the admission criteria to accommodate the new needs of the population. And this it can be seen that they were able to accommodate the changing needs. So from only war-related wounds to also non-war related. So this also justify this peak. And last, I wanted to report this graph, which instead is about reasons for consultations in first aid posts or in Lashkargah. And it's very interesting to see that there has been a shift in reasons for consultation. While before August 2021, the reason was mainly for war-related injuries or like violence-related injuries, shell and mine on the one hand, the bullet and stab on the other. We can see that the non-war related has sharply increased after August 2021, which once again confirms a changing pattern of needs in the country. Moving now to the results of the questionnaire. This was our sample. I will not spend much time on this, just wanted to mention that for the majority, they were living in rural areas. For the majority, they received no education. They were farmers, and more than 70% were male. The majority was in the age range between 20 and 40 years, and more than 80% were married. We also investigated the main source of health information. Probably here, what is interesting to highlight is the main differences between female and males. As you can see, for males were increasingly seeking health-related information by consulting healthcare professionals, where females by consulting family or friends or mass media. And although the majority of participants considered health information accessible and understandable, there was still a difference across genders. What is also very interesting is to look at how do people usually reach healthcare facilities, and it's very striking to see that the lowest percentage is through public ambulances. Probably the most interesting results of our study, we managed to understand whether patients have perceived an improvement or a worsening in their different components of their ability to access care after August 2021. As you can see, the majority of people perceived an improvement in their ability to access health information and in the sense of safety when visiting healthcare facilities. the majority felt that their ability to reach care has remained the same, instead, the majority of patients reported a decreased ability to pay for care. For each one of these abilities, we investigated the main reasons for either the improvement or the worsening, as you can see in these pie charts, as well as groups that were more likely to report a worsening. So if we want to call it them like that way, more vulnerable. And in this case, for the ability to access health information, for example, we found that women, those who were separated, widowed, or divorced, and those who are not the head of the household were reported more having seen a worsening in their abilities. We applied these for all the 4 components of access to care. I will skip those, but once again, I encourage those who are interested in checking the report, because I want to move to the results of the interviews. We conducted, as I mentioned, 43 interviews, 11 with directors of national or provincial hospitals, and 32 with members of emergency staff. As for the health professionals, they also confirmed that the ability to pay has worsened. Patients have to buy medicines and consumables by themselves in public hospitals, even though care should be ostensibly free. And they also started engaging in some coping strategies, such as selling their properties or borrowing money or foregoing treatment at all. In terms of ability to perceive, it was reported that the tendency to delay care until a condition has become acute, so an emergency, has worsened after August 2021, and this is especially true for women who at times skip antenatal consultations until the delivery. They also agreed that the ability to reach healthcare facilities has improved, especially in those provinces that were mostly affected by active fighting in the past. However, the cost of transportation is still unaffordable for the majority of Afghan families. Besides these changes in access to care, many healthcare professionals reported some chronic challenges that are affecting the healthcare systems independently of the change of government. I will just mention some of the most interesting things that have emerged. So they reported that specific categories of healthcare professionals are lacking. This is especially true for laboratory and radiology technicians and biomedical engineers, which has repercussions on the functioning, on the use of medical equipment. Other interesting findings, healthcare professionals reported of an inadequate distribution of facilities. Sometimes they mentioned that there are some bottlenecks in big hospitals in cities, while lower levels of care tend to be skipped. And we also found that they reported suboptimal care and knowledge about NCTs and chronic conditions. Just to conclude a few key messages and key findings, we found that overall we can conclude that security and safety alongside with affordability of care are the most important factors influencing people's ability to access care. So recommendations and actions should be taken in these areas. Women are a vulnerable group, and this is especially true for maternal care. The increased mobility in the country and the uneven distribution of facilities have caused an increasing number of patients, especially in big hospitals in cities. And last, I wanted to conclude saying that in the interviews, we also managed to ask respondents what would happen if the international community left the country. And many interviewees agreed in saying that the whole system, according to them, would collapse, which we thought it was an interesting result. So that is it from my side. I think I was also on time.
Thank you, Martina. Yes, you were on time. Just for the audience, we will leave room for questions at the end of all the presentations. So for those who would like to ask questions, please write them in the chat, and we will do our best to ask our speakers your question during the final discussion, and also to discuss some recommendations. But as our presentation, our report was focusing on the changes in the health system in the access to healthcare and the system in Afghanistan. I'm very happy to introduce now the next speaker, who is Dr. Wahid Majroh, who I had the pleasure to meet when he was Minister of Health in Afghanistan during a very difficult time, because he was there during COVID-19 time and also stayed after August 2021 and trying to keep as much as possible the continuity of services in the health sector. Dr. Majroh is currently sitting on the WHO Executive Board and is dedicated to promoting health and peace through its Geneva-based organization, which is called Afghanistan Center for Health and Peace Studies. Dr. Majroh is also an academic fellow at the Geneva Humanitarian Studies Center, focusing on research articles delving into health system resiliency in the fragile setting. And I think that you do have a wide experience in this sector. So Dr. Majroh, the floor is yours. Thank you.
Salam and greetings. Thanks, Rosella, for the introduction, especially remembering the days when we had the pleasure of working and meeting our colleagues from Emergency. Not happy days, but I believe that the proud of those days will always be the highlights of our careers. Let me, if I can arrange the...
We can see the screen.
Okay, great. Thank you very much for providing me this opportunity to share my viewpoints on the current status of the health system in Afghanistan, and the prospect for future, and what are the opportunities and challenges out there. I will focus on the theme of the webinar, which I really appreciate the efforts made to conduct this event. My speech presentation will cover two aspects. One is what is to be considered as a continuum of care for people out there in the new context, in light of the experience of last 2 or so decades. And the second one would be what are the human capital requirements for that, and for which I will present a reason why, out of several inputs needed, I have focused on human capital. When it comes to what we deliver, what we provide for, what the health sector is to provide for people, my experience of last 2 decades and the evidence out there shows that it is the time to come up with a more holistic approach to continuum of care. What I mean with that is that, and why I advocate for this shift in policy, is that good or bad, which I appreciate the efforts made in the year 2001 to 21, the health system was shaped in the mindset out there in a way which is too PHC-centric or BPHS-oriented. There were logics, which I don't want to comment on that, but the lessons learned and the outcomes and the evidence available to us tells us that the way we looked at the health system in just post-2001, in the evidence, in the available demographic data, is not just responding to what we have today. So that PHC or BPHS-centric approach or mindset caused the big part of the continuum of care to be what I was calling them as orphans. If you look at the amount of investment made in the last 2 decades, the number of international and national institutions focusing on service delivery in Afghanistan, you realize a huge imbalance between PHC services in that which covers either NCDs, emergency care, and the institutional capacity to ensure that it has the required means to come up with policies which are future-oriented. So the first thing which I will emphasize is a shift in policy to make sure that it is not only focusing on BPHS, it is not only focusing on PHC, but while keeping that as the main part of service delivery as a path to UHC, it should ensure that other components, or if I put it in more simple words, besides mother and child, fathers in the youths, which are the main drivers of economies of today, are also somehow covered. And the change in demography and the change in burden of disease is contributing to policy making from now on. And that requires the health sector as the steward in the ministry to come up with a more comprehensive and inclusive health strategy, that in context of that strategy, a new priority package that I'm sure Professor Karl will further elaborate on that is required. And when we were out there leading the health sector, we worked on a new package of integrated package of health services, which Professor Karl and Geneva University were our main partners. I don't want to go further into the details of that, as said Professor Karl may talk about that. So the second component is the resource allocation. So once we have the shift in policy, we have to make sure that there is a balance. Inequity does not only focus on the recipients, but it starts from the policy making level. There is a huge inequity when it comes to those who need PHC care and the other part of the society, which are in need of emergency care or secondary care, different parts of the community. We hear a lot that the Afghanistan preserves the highest out-of-pocket expenditure in the world, or one of the highest. But if you go into the details, the big part of that cost comes out of the reason of caused by unavailability of secondary and tertiary care in the country, and those needs which were not fulfilled by a BPHS-centric health system, which not only lead to financial catastrophe in the community and family level, but a higher rate of DALY and CALI as well. The third issue that I want to focus on is community engagement. Because for the reason which I explained, the health system was focusing on BPHS from the beginning, so the demand is not generated much out there in the society. It is not only at the community level, even if you come to the policy making level or political level, somehow the expectation out there at the community of just having a health sector being able of providing services beyond vaccination or other basic healthcare services is not there. So we have to not only include these inputs within the system, the services, but make sure that there is a demand at the community level. So we have to work both on supply side and demand side to make sure that utilization is out there, and that will contribute in the longer term in improving the just current dilemma of financial catastrophe and the DALY and several other issues related to the burden of disease in the country. In the interest of time, the second component of the policy shift that I will focus on is the human resource for health. When we talk about human resource for health, unfortunately, the main focus in perception is, okay, having female doctors, which I really insist on that, and I appreciate that, or having, for example, midwives or others. But what the health sector is suffering today, besides all those historical challenge, is the brain drain, causing health sector being depleted from the human capital to ensure that it has the capacity to develop policies, strategies, in the vision that can not only address the historical challenge of unavailability of human capital and imbalanced distribution of human capital. It is not, I appreciate the way your research findings were shaped. It is not only the maldistribution of health facilities, but maldistribution of available professional capacity as well. Just in simple terms, first, there was an irrational distribution of professional cadre in big cities, and in rural areas, big provinces like Herat, Kabul, and Zabul. On the other side, when it comes to disciplines, the specialty program or the postgraduate program in their workforce planning should be revisited, because you have too many internal medicine specialists, while as the COVID-19 or the emergency crisis showed us that we lack ICU care specialists, and that was one of the requests that I'm thankful of emergency that they at least at that point agreed to start it in Panjshir and also in Kabul, or when it comes to biomedical engineering, to radiology, to rehabilitation care, which is a huge need out there in Afghanistan. You don't find the human capital out there. So there is a maldistribution of health facilities, but it is further exacerbated by the maldistribution of proficiency in irrational distribution of that. Female healthcare worker is a serious issue which has to be addressed. It takes time. So for that, what I propose is a short-term and a long-term approach. Task shifting is one of the key initiatives that I've always advocated for, and we have examples of the absorption capacity out there within our midwifery cadre that could be invested on. Retention strategy. So besides addressing the historical challenges we have in human capital, retention is another issue. In the past, it was when it came to payments issues, the NTA strategy of the government was a bit effective, but post-collapse of the government, there was again a high level of payment in international organizations, programs, and which is not comparable with the government. And what I hear, the least number of staff members who have remained in the country moves toward those vacancies. That's one challenge. There are many issues which are linked not only to the Ministry of Health or the health sector, but the other determinants. So the social issues has caused people just consolidate within big cities, and that has caused depletion of human capital or lack of interest for professionals to go to the rural areas. And that's where we can leverage the digital health to make sure that we can contribute in short term to the needs of people out there. This challenge is further exacerbated with the recent brain drain in the country. I should say that at some points it has been unfortunately pushed. The depletion or just evacuation of the ministry from all professional human capitals, which most of them were not politically affiliated with the government, but technical experts, is a challenge, and that will be felt in longer term with the unavailability of required institutional capacity to come up with context-oriented policies and strategies. The last but not the least is training and education. So in light of what I explained, there's a huge need for revision of how we look at the human capital training. The workforce planning approach should be completely revisited to make sure that it responds to the short and long-term needs, and what we need is somehow linked to the burden of disease of today and the change in demography. And that is something that requires intersectoral collaboration and coordination. We had initiated it, but anyways, I don't want to go back to the stories that were left unfinished, but at least there is a huge need for coordination between the Ministry of Health and the Ministry of Higher Education, because to make sure that what they produce is according demand-driven of not only for today, but for tomorrow as well. And in that part, the female healthcare workers is the main should be the main component, and the problem out there is that everybody is, including the current minister, complains about unavailability of human capital, female human capital, but on the other side, the human capital production route is completely blocked, which is not just disastrous only for future, but for today, but for future as well. So with that, in that field, we have to work with international organizations to make sure that in short term, until a change in their policy is witnessed, we can use online in other possible use of digital technology to deliver the possible level of knowledge and transfer knowledge to available female human capital out there in the country first. Secondly, which I am really critical of how international organizations have approached the diaspora community of medical professionals. There is a huge potential that could be linked up back with the health system in community within the diaspora, and that requires a further engagement of international community. In the center that we have established here in Geneva, one of its main purposes and agenda is on how we can link up the human capital and the initiatives we have within the diaspora community back to our health system in Afghanistan, given it be public or private centers. As conclusion, to improve access to healthcare services in Afghanistan, it is a complex context. It is a contested context, and it requires a sophisticated and multifaceted approach. It has to make sure that it responds not only to the short-term immediate needs, which our international partners within the humanitarian aid components are focused on, but to ensure that the stewardship and the governance and leadership capacity is out there at the national institutions. And that requires both political advocacy to make sure we have an apolitical Ministry of Health out there, and on the other side, to ensure that the inputs are used in an efficient way, because our experience of last 2 decades shows that the level of support which goes on during the honeymoon of today will not continue for long. First. Secondly, Afghanistan's history has proved that nothing is the same as always. The same problem when it comes to, as an example, when it comes to emergency care, the same problem of 2001 is being replicated. And what I mean by that is that everybody thinks that Afghanistan is out of emergency phase, and the resources, the technical capacities, and institutional memory is somehow removed. And if we close emergency hospital out there, then the national institutions does not retain the capacity it used to have. And I try to remain optimistic, but at the same time, the history has taught us that we have to be prepared for the worst case scenario in Afghanistan to make sure that we ensure the national health system has the capacity and the means in the human capital to respond to emergency cases of what we experienced a few years back, and our memory should have not forgotten that. So with that said, I will wrap up my words that we have to make sure that it is not only the international organizations, which I respect and appreciate their efforts, that shapes what is to be delivered to the people, but the national institution, including what the international organizations bring in, should come up with a more holistic healthcare package, which does not left out specific parts of the community. It has to make sure that it does not further push brain drain, but facilitate the ground to relink with the diaspora and just leverage the brain gain in the capacities which are now being developed or developed in other parts of the world, can contribute to the health system in Afghanistan. With that said, I thank you. Thank the panelists and all participants and colleagues who have helped us yesterday, are helping us today, and still out there to contribute to the future of Afghanistan. I will remain here in case of any questions. Till then, I thank you very much.
Thank you very much, Dr. Majroh, for this very broad picture. And I can witness that most of the challenges that you mentioned are still there, and we are daily trying to overcome them. But also on the positive side, I have to say that many of the projects, issues, particularly in terms of training of healthcare professionals, that we started to implement back in the years are still ongoing, and we are still finding interest and willingness at local level to bring them forward. I have to say that it's more difficult to engage the international community in this field. So I'm definitely very, I mean, I do agree with all the inputs that you provided us. That lead us also to another very important issue, which is the resilience of the health sector. No, this is something that we, from different point of views, but we all want to go there, basically. And in this regard, I'm very happy and proud to introduce the next panelist, Professor Karl Blanchett, who is the director of the Geneva Center of Humanitarian Studies and professor in humanitarian public health at the Faculty of Medicine, University of Geneva. Professor Karl has worked in Afghanistan since 2018 and assisted the Ministry of Public Health in developing the integrated package of essential health services. Karl is now involved with UNICEF on operational research, and today I hope that he will, I'm sure, that it will give us a very important input into what resilience is, particularly in the context of Afghanistan. So the floor is yours. Thank you.
Thank you very much. So I hope you see my slide and you can hear me. So thank you very much for inviting me. Thank you to Professor Sasso and you, Emergency, for organizing this very important webinar, and thank you to Dr. Valente for presenting the report and this very interesting study. I tried to make sense a little bit about the resilience of the health system in Afghanistan. And we all had predicted that the system would collapse with the new regime. It did not happen. It did not collapse. It has survived in different ways. And I would like to show some of the different aspects that have survived, but as well I would like to take the opportunity maybe to revive some ideas, some may be new, but some may be old, about what needs to be done and where we need to invest in Afghanistan. Oops, okay, here we are. So first of all, what we need to understand, if we want to talk about equity and we want to make sure that everybody is going to get access to services in Afghanistan, we talk about universal health coverage. And we do that in a context where we have a lot of inequities between different groups, and Dr. Valente Martina has nicely presented that. Different groups of population, either by gender or by age, or even when we talk about refugees and IDPs, that's exactly the same, do not have the same access. But as well, there are differences between inequities. And in the report is very, very clear that there are different provinces or different districts that do not have the same type of access for different reasons. It could be geographical accessibility, and before 2021, it was due to a high level of violence and insecurity in the country. And what we need to understand as well is that 75% of the country is funded by families. Okay, there's this myth that actually international funding donors are the ones supporting the holding the system in place. That's not the case. Families are paying 75% of the expenses of the system. Of course, the ministry and national authorities, but as well international donors, international organizations such as emergencies, are playing a key role in investing in areas that are often underfunded in this kind of context, and emergency care is one of them. And of course, in this kind of system where we have international donors, we have as well a high level of fragmentation into the system, where we have many different organizations working in the same geographical areas and sometimes working in the same type of services. And I'm going to show that in a few seconds. But in this kind of context, very surprisingly, and I have to praise the leadership of the two ministers I've worked with, and Dr. Majroux is one of them, for the incredible leadership and to have actually achieved some great success during the last 15 years. This country, and that these are the latest estimate for IHME, has experienced a lot of changes, and the epidemiological transition from infectious diseases to NCDs, and Dr. Valente and Dr. Majroux have already explained that, require to actually include that in the way we're going to rebuild the system. And it is very clear that the priority conditions now in Afghanistan are very much around these issues. Many other conditions are not actually included in these priority conditions. These are the kind of priority settings we had done with the two previous ministers, but very much looking at the capacities of the system and how they can sustain. So as you can see, some of the health conditions have not been included for very good reason. I could elaborate a bit later. But these are the conditions that the country should do based on the needs, the priority needs of the populations, but as well on the capacities of the system to deliver quality services in these areas. It's very clear. This is a latest figure from WHO on the level of or the portion of population that has been underserved in the health system. As you can see, 65% of the population do not have proper access to health services. And so in Afghanistan, they talk about white areas or underserved settlements. Or white underserved populations as well. So it's quite a high number when you think about it, and this number might increase. And I think Dr. Valente in the report is very explicit about that, and you have experienced that. So that's quite alarming. But if we look at, I want to focus on the primary healthcare system and the community health system. So what we need to understand is that there are plenty of different facilities contributing to the district primary healthcare system. The district hospital is one of them. We also have the community health centers, and to make it even more complicated, we've got the plus ones. So the ones that have been upgraded, but that's not over. You also have the basic health centers. We also have the sub-health centers. And to make it more complicated, in some districts, we have the FHH, the family health houses, created by UNFPA and integrated into the ministry in some areas. But it's even worse than that. We also have mobile teams going around and sometimes disrupting the delivery of services. And so one of the key, and that's one of the latest trip I made with UNICEF on primary healthcare, is very much to try to, how can we bring coherence within the system? Because the worst is coming. Not only we've got a high number of facilities with level of specificities in terms of human resources and services they are supposed to deliver. But the links between these services is not very clear. There is some loose one in terms of referral system, but it's not very clear as well in terms of supervision. So very surprisingly in Afghanistan, if you the community health centers or the basic health centers do not seek for advice to the upper level, which is a shame in terms of quality of care. Quality of care is one of the key issues in Afghanistan because it's completely undocumented, and that's something we need to work on. And by creating a proper system where facilities will be linked to each other, that will be much easier. Another aspect I realized, and was very astonishing in my latest trip, which was if you a male elderly as well, but if you're a male, or if you are a person with chronic conditions, the primary healthcare system is not for you at all. You will not find the right services at this level. You will need to go to the hospital, District 1 or the one above at the province. So UHC is not only about who we're going to reach, but it's also about how, and it's also about what kind of services we're going to deliver. What has been very fantastic, and that's part of the resilience thinking around that, is that the community health system and the shuras have not collapsed at all, and they have been very active doing after the collapse of the previous regime and under the Taliban. And that's something very fantastic that could help strengthen the whole health system, including the hospitals, in terms of referral, in terms of identifying where patients are, not only in terms of chronic conditions, but as well in terms of emergency care. We can save a lot of lives by having this whole system from community health to primary health care to hospital working. When we talk about, and Dr. Majroux talked about that, I do think we need to have even more clarity on the what kind of services is to be provided in Afghanistan. And Afghanistan has this fantastic experience in priority package and since 2005. And in 2021, we had finalized under the leadership of Dr. Majroux this package of services. And of course, this package has not been implemented by the UN or by all the healthcare providers. We've got a plan. There's some very good discussions, and we hope that's going to work, to redefine a priority package for primary health care. Not only creating links between facilities, but as well making sure that people are very clear on what they need to deliver. And finally, my last slide is very much about when we create this kind of package, we have a lot of dilemmas in mind. One of them could be about, okay, priorities, but what kind of services? That's one of them. The second one is how to create equity within the system, very much what Martina had presented. And the second one is also about what kind of trade-off are we going to make between clinical care and public health? And I stop here. Thank you.
Thank you very much, Carl, for this very interesting presentation. I do think that community engagement, and I can tell you that this is, they're still giving really a lot of contribution. We are experiencing this also to develop health education within the community. So also in terms of how to access and when to access which kind of level healthcare facilities. So this is definitely our experience as well, but we will go back later. Now, I would like to move out of Afghanistan because actually healthcare for Afghans is not just a problem for those who are in Afghanistan, but as we all know, Afghanistan is one of the countries with the highest proportion of refugees in the world, many of whom are in Iran, and the number increased a lot after August 2021. And to talk about these challenges, we do have the pleasure to have Professor Amir Hussain Takian, who is Professor at Global Health Policy and Vice Dean and Director of Center of Excellence for Global Health Education and Research at Tehran University of Medical Science. He is also a member of the Executive Committee of the World Health Summit in January. And Professor Takian has been doing extensive research on Afghan refugees' health in Iran and in Europe, also in Germany, during the last 5 years. And he has been an advisor of WHO, IOM, and UN on integrated refugees response plan in Iran, and has also published several research and articles on this subject. So, Professor Takian, the floor is yours to your presentation. Thank you.
Thank you very much, Francesca, for your nice introduction. And I hope you can see my slides and you can hear my voice as well. And I assume that's the case. Okay, great.
Thank you.
And thank you, Emergency. Thank you, Professor Sazo and World Health Summit and all colleagues. I enjoyed very much the presentations. And because we have a limited time, so I try to be very quick. Actually, what other colleagues mentioned, specifically the context that Vahid put the scene and what Carl mentions sets the scene for what I want to say. What I'm going to talk about is about sustainable healthcare financing for Afghan refugees in Iran. And the reason I am interested in this is the work that we did for the United Nations and for the World Health Organization with regards to this. Carl mentioned about universal health coverage. When we talk about universal health coverage, we have the kind of situation of refugees when before they enter the country, they have many issues like mental disorders, like injuries and things. When they enter the country, many of these can be resolved, which is not necessarily the case in Iran. But some of them, like cardiovascular diseases, chronic diseases, and non-communicable diseases, are about to increase. In the context of, there are many models of providing healthcare for refugees and migrants, like mainstream services, which means that the migrants and refugees enjoy the services which is integrated into the national health services of the host country. And Iran has adopted this way. So almost 9 million Afghan refugees in the country have access to this kind of services, not a kind of very good access, but we have adopted this kind of access. There are other models like limited services, mixed model of care, which is not the focus of my talk. So I just wanted to mention that from the very beginning in the course of last 4 decades, we have adopted mainstream provision of services. Carl mentioned about out-of-pocket payment in Afghanistan, which is really high. When it comes to Iran as well, and when you go to the global picture, that's the case. I just want to put you in the picture of why financing and sustainable financing matters for Afghan refugees in Iran and for all above 100 million refugees around the world. I mean, we suffer, many countries, including my country, financing for health is insufficient, inefficient, and inequitable. It is insufficient because about 45 poorest countries will be lacking about, and they need a kind of big money, which is about 176 billion per year. So they don't have access to this fund. There is inefficient, almost 30% on average of this health spending is wasted in my country as well. So even we have money, we waste that money. And unfortunately, this is the most heartbreaking one. The people in developing countries spend $500 billion each year out of pocket. When Carl mentioned that 75% of money comes from families and almost 100 million people globally go into extreme poverty, this means that the extent to which we need to be very careful to provide financing, and that financing should be equitable, and that's why we need new models. When you look at the innovative humanitarian health financing for refugees, this is a general model. There are different toolkits. One, for instance, pre-emergency and multi-year planning, health insurance bonds. Some countries have started to have health insurance bond, concessional loans, the donors, and pay for performance. So basically what happens is, for instance, in countries like Afghanistan and for Afghan refugees in Iran, a small proportion of funds comes from donors. Vahid remembers that 6 years ago, and interestingly, with the help of the government of Italy, we asked the government of Italy in Iran to provide of some funds, and then we received the funds, and then we provided some kind of maternal facilities for our colleagues in Afghanistan. And then we created a kind of Afghan-friendly hospital ward in the city of Tehran. And these funds are from the donors. But as mentioned by other colleagues, these are not sustainable. Sometimes these are disruptive. And then when we put all these funds together, then there are some facilities at the district level in Iran, for instance, and there are other facilities by the United Nations, NGOs, faith-based organizations, and the private sector, which somehow use these funds to provide the services. And as I said, these are all unsustainable. In the context of Iran, which I want to concentrate and then introduce you very briefly to what we have done, the official statistics says that in Iran, we have about 4.5 million Afghan refugees. Actually, before the change of political regime back in August 2021, it was about 3 million. Almost 1 million were documented, so they had visas or legal status in Iran, and almost 2/3 of whom, say 2 million of those Afghan refugees were undocumented. After August 2021, the situation now is about 9 million, 8.7 million, we believe, of Afghan refugees. And you can imagine that all difference between that 1 million and this 9 million are illegal. So the majority of those refugees are illegal. So the majority of this, so there is no solid number, but the majority are undocumented. So they have the fear of being deported. They have a fear of being discriminated. They don't have enough resources. And then if you look at the age group of those Afghan refugees, you can see that almost 90% of those Afghan refugees are young. There are people under 40 years old. They are the working group people. That's why they are very reluctant to go and get insurance. That's the thing. What I want to concentrate after this context is health financing. I have done a couple of works for the World Health Organization. For instance, this document, the pink one, is the model which I'm going to introduce. And recently, I had the pleasure to advise the United Nations, the IOM, UNHCR, and the WHO for the refugee response plan, which is going to bring all the attempts of the UN organizations under one roof to avoid waste. Because as I said, 30% is wasted. We wanted to bring the waste down. So what we did, we thought we bring all the resources, all the issues and the challenges under one roof. And then part of that is addressing the barriers and challenges to migrants' financial risk protection in health. In Iran, there are many, like for instance, the ability to approachability and perceive, the ability to seek and acceptability, the ability to reach and availability, and the ability to pay and affordability, and the ability to engage and appropriateness. So these challenges needs some kind of innovative financial approaches. In the course of last 4 decades, when Iran has been hosting Afghan brothers and sisters, what we have done is a number of initiatives. In summary, one thing which was the most innovative one was insurance, the basic insurance for Afghans. So there was a kind of 3-dimensional contract between UNHCR, the Ministry of Health in Iran, and the Iranian Health Insurance Organization, which is one of the main upstream providers of basic insurance, to provide insurance for Afghan refugees, and specifically for the documented one. But unfortunately, as we can see here, the majority of Afghan refugees, because they didn't have enough funds, they didn't have enough resources, and they were young, they said, we don't need them. But for those, even they are undocumented, in terms of access to free services for public health and for primary health care, they are free. They are free of charge, even they are undocumented. The only thing that we charge them is if they are undocumented and they go and use some kind of secondary care services. But you can imagine that given the financial constraints that Iran has been facing due to sanctions, due to shrinking the national domestic product and other things, so there is no enough funds for that. And then what we did, we conducted a very comprehensive social network analysis in order to understand who are the stakeholders who are engaged in that. I don't want you to somehow understand all these acronyms, but you can see there are many players. And this refers to what the previous speaker said about how difficult and how complex and complicated and multidimensional and multiplayer is this thing. You can see that there are different organizations, different countries, different national organizations, some of them with more power, and some of them with the conflict of interest. So we identified if we want to provide sustainable financing, we need to do something. And this is the situation of finance in Iran. And you can see that the blue bar shows what we need, and the yellow bar shows that what we have received. And you can see that even though some of these countries, for instance, the government of Italy, as I mentioned, the Japanese government, the Swiss government, UNAIDS, the Qatar Airways, for instance, based on the corporation, business corporation values, they have been contributing to this fund. But always we have been running out of the resources. And unfortunately, if you compare the year 2022 to 23 or year 21 to 23, we can see that sometimes we have been even we have had access to less funds for having this, and that's why the most of funds has not been available. So we started to see what we need to do. The first thing was using the sources which are more sustainable. And I've put one of the examples. For instance, we received some funds from the UN organizations that like UNAIDS or from some international funds like the Global Fund to fight AIDS, TB, and malaria for some specific diseases. So we identified some cases, and one of the issues that we have with Afghan refugees, for instance, is the multi-drug resistance TB, and TB is the big issue. So we diverted some of those funds for the Afghan refugees, for instance, or in order to somehow bridge the gap. You can see that in the year 2022 globally it has been 13 billion need, and the materialized fund has been about less than half, 40% of each. So you can see this has been the case. But we tried to pool 4 vital packages, which I come to that very shortly, in order to use this facility. And my main point is this diagram. This comes out of our research for the World Health Organization to identify the ways that we can increase our revenue in a sustainable manner. And these numbers, for instance, donors and related organizations, taxes, religious affairs, social protection agreement, and disease-based financial resources, which I just mentioned, for instance, for TB, for HIV, regional treaties and cooperation like Qatar Airways, for instance, dedicated revenue from bilateral and economic opportunities, banking system, premium out-of-pocket and franchise, employer-based schemes for some Afghan refugees who are documented and who are employed, and health volunteers. These are the revenues. We have 2 big organizations in Iran, Iranian Health Insurance Organization and Social Insurance Organization. So what happens is in our model, we have the funds coming from these sources, and then we have 3 different packages. One package is compulsory vital pack, which is the services which are life-saving. For instance, some very, very important diseases like TB, for instance, or the diseases with some kind of consequences. There are some basic packs. The most common diseases like cardiovascular diseases, which are very costly, and complementary packs for elective issues in medicine. So then we decided that for compulsory vital pack, the government of Iran should be responsible, and we prioritize the funds from these all 10 sources towards this, and then we give the funds to these two insurance organizations, and then we provide them for all Afghan refugees, irrespective of their legal status. And for the basic packs, which started to go and find some people and some organizations and some countries, like for instance, this year we are working with the government of Japan for that. And then this compulsory benefit package can use these sources, which I just mentioned, pooling at HIO. And then one thing which is the challenge is making the refugees and the migrants aware of the situation and their rights. And something which we have been working on is e-insurance card. So rather than forcing Afghan refugees to go and apply for the insurance card, then we have the mobile phone. Then we can provide the insurance package on the mobile phone, and we need to go among them. And because the majority are young, the majority say we are not suffering from any diseases, we don't need any medical assistance or something. We need to promote insurance culture among them. And then those insured and uninsured, and those undocumented and documented are entitled based on this to use the facilities. My last point is this: basic insurance package. Then we have divided these into different categories, pulling at these two organizations. And then reproductive and newborn, for instance, they have some packages, younger than 5 years. These are the most vulnerable groups. Then the teenagers and the adolescents, then the adults, and then the elderly. For each of these, I don't have time to go to this, but there is a comprehensive report available on the WHO website, and it's the journal article is being prepared to use this. I want to stop with this, that new financial approaches, which somehow, for instance, Makiba in Kenya, which has been facilitated by the World Bank, has been facilitating the use of blockchain, a smart blockchain, and then some bonds, for instance, the social impact bonds, they have been used to reduce asthma. So we have been somehow approaching some wealthy people, some organizations, and some others to invest in the kind of blockchain and cryptocurrency in order to reach Afghan refugees. And then by this, we have been successful, actually, not very, very much, but in some degrees to do this. So this is the model that the World Bank has been using. And then community-based health insurance, for instance, which we have been using for Afghan refugees who have been suffering from some rehabilitation issues in some rural areas. Just to finish with, some of our work has been published by different journals. For instance, this one by International Journal of Public Health that has a good SWOT analysis of what Afghan refugees need, and then the policy recommendation for health policy financing, for better access to the healthcare services, or one of the things that I have done with my colleagues in Germany, which is the comparison between Afghan refugees in Iran and Afghan refugees in Germany, and the way that these two nations who host a big number of Afghan refugees can enjoy from and do that. And I hope by advocating these financial models, one of the biggest barriers to universal health coverage can be addressed. Let me finish by this poet from Saadi Shirazi. Our famous poem says, "Human beings are members of the whole, in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain." Thank you very much, Francesco. I hope I didn't consume much of your time. Over to you.
Thank you very much, Amir, also for this conclusion, which I do definitely agree with. From our point of view, access to healthcare is something that has to relate with human rights and with us being all members of one family. So for sure we share, I think, the same approach. And I really think that the model that you are implementing in Iran can be a significant example also for Europe, I would say. So we have 10 minutes left and I would like to open the floor to questions, if there is any. I don't know how to, let me see, from there is a chat. Okay. So if there is no question from the audience yet, I would invite all the participants, please, to write down your question in the chat if you have. Meanwhile, I would like just to ask to the three, or to the four actually, panelists the same question, and if you can please just give a very brief answer to it, because we don't have much time. But what we have seen from different perspectives today is how important it is to invest in the healthcare sector, and which is not just a matter of delivering drugs, but it's really strengthening the entire system of the country or of the neighboring countries as well when we talk about migration. How do you see the way forward? I mean, how can we, or if can we join forces in order to make sure that this message in terms of investing in healthcare in Afghanistan as a complex system that not just stops at the level of PHC, but goes into secondary, tertiary training, infrastructure, biomedical quality of drugs and supplies can be really, can still be considered a priority for the international community, not only for the Afghan people. I would start from Dr. Majroh, perhaps, and then Martina, Carl, and Amir. Please, the floor is yours.
Thank you, Rossella, for the question. I see opportunities in the current context as well as challenges. There is a huge opportunity for improving access, as well as just the level of contribution by international community compared to the dwindling trend that the last years of the Republic was experiencing. So that's the opportunity. But on the other side, I'm deeply concerned for lack of a systemic approach from the steward institution to make sure that the system retains the capacity not to deliver today, but to prepare for tomorrow as well. The health system, as part of a bigger national institution, enjoys what I call the honeymoon, which the Republic enjoyed in 2001 and thought that it will continue till beyond 2021, which unfortunately did not. So what I call on our international partners is to work with the national institution, to provoke them, to show them different scenarios, to make sure that they take the responsibility and not being shocked a year or two from now when emergency says that, sir, we don't have the money to run the other 40 clinics beyond the 4 hospitals we have. That's what I was always receiving from different partners, and that will not be a new example. So in different parts of the world, the international aid, especially humanitarian aid, will not continue forever. But at least in the Republic, we had a gradual development of national institution capacity and a gradual handover of responsibility. But this time, what I try not to be pessimistic, but find on the ground is that the institution will not be able to take over the current what I call just the unplanned and unequal establishment of new centers, which I hear every day. A new NGO comes in with new a few number of BPHS health centers in several parts of the country where it is not part of the national institution's strategy, because we all know that establishment of a health center is easy, but running and keeping up and meeting the expectation out there at the community level is a different story. So with that said, what I will call for on our international partners is that first, thank you for your contribution. Second, make sure that you take that level of responsibility that you're expected for, not to make sure that others will feel just irresponsible. Thirdly, a huge level of coordination is required, because efficiency matters, and the national institution will not be able to pay the current level of expenditure. Fourthly, we are expected to work directly and through the national institution with the diaspora community. That's a huge potential missed out currently, and I look at that as an added value, because at the end of the day, this will be Afghans who are expected and will be all responsible to take on the leadership of service delivery, given it be in humanitarian phase or beyond that. So that is overall what I want to explain. It is a mixed picture of opportunities and challenges, and it depends on different role players out there on the ground, that how can they leverage the current context. I thank you.
Thank you very much, Dr. Majroh. Martina?
Yes, thank you so much. I will be brief. I just wanted to add to what has been said that I really liked the red line across all the presentations, stressing about the holistic approach, integration of different facilities and levels of care to direct efforts and avoid duplication. And I think that is quite, and in fragmentation, I think that was quite interesting. I think that might be also the way of action to make sure that the system can be functioning and sustainable. And it's also interesting to see that perhaps what we considered collapsing or like not resilience indeed might be resilient, as Professor Blanchet was mentioning, which was quite interesting to listen. So yeah, and also as we suggested in the report, I think this could be possible also through pragmatic, flexible, and constructive engagement with Afghans, authorities, health professionals, and communities over there. So that would be my point.
Thank you so much, Martina. Since you mentioned him, I would leave the floor to Carl.
Excellent. So I won't be very long, because we are already running out of time. I do think that Afghanistan is now suffering from the competition from other crises, unfortunately, and I'm sure emergency, you are struggling to try to find extra funding for Afghanistan. It was first Ukraine, and now Ukraine is facing the competition with in Gaza, and so on and so on. So it's incredible to see how one crisis is pushed by another one, unfortunately, and that's it's a mistake to think that resolving one crisis after the other one is going to resolve that. But yes, I think it's the funding space, as Amir explained, is shrinking, and we've seen that the Iranian graph on the link between 2022 and 23 is astonishing. How the gap of funding is so much in between the two different years. It's just astonishing to see that. And but I hope that all of us are going to continue to work in Iran with refugees and in Afghanistan. So here we are. That's all I hope, and we need to keep faith in our partners and in our work.
Sure, and I can confirm that the increasing crises worldwide are definitely affecting the attention, not just the resources part on Afghanistan, where, for example, we have just recorded 4 new attacks only in Kabul over the last 10 days. So the situation is still far from being stable and out of the emergency. Last but not least, Amir, please.
Thanks, Francesca. I know we are running out of time, but I am optimistic because we are facing good opportunities for new investment and finding new donors and new models of financing to push for universal health coverage, which is very difficult in Afghanistan. And my second point of optimism is the people in Afghanistan themselves who can contribute, and many Afghans out of Afghanistan who can contribute to this initiative. That's the source of optimism. Why I'm pessimistic, it is what exactly you mentioned. I mean, the course of last 4 years after COVID-19, we have been facing, unfortunately, the vacuum of good governance and global leaders. This has somehow pushed many countries, and specifically the vulnerable countries, towards more problems. And then, as you rightly mentioned, anytime that we want to somehow come to a kind of relief with some context, then another starts. So Afghanistan, then Ukraine, then Gaza, and then, I mean, this kind of continuous disasters added to the climate change consequences, which affect, I mean, let's do not forget that even people inside Afghanistan, like people inside Iran and many countries, are being affected by the natural disasters, the climate change consequences, which worsens the issue, and the context, which is very important for health, like access to food and this kind of things. So this very complicated picture makes us very concerned about what to do. But the only thing which we can address this is trying to find solutions, working together. And what you do, Francesca, Dr. Valentin, Martina, and others, is fantastic, because we need to put these resources together. We need to share what we have to do whatever we can. Otherwise, there is no other way to go ahead. And I hope this kind of initiatives can bring us together to address these issues. Over to you. Thanks.
Thank you so much, Amir. I mean, we are just 2 minutes late, so I think that all in all, we did a good job, and I don't see any other questions in the chat. But I would just leave by saying that since we all agree that this is a very important issue and topic, we will continue to work together, because the need is there, and we will not give up. So I will give back the floor to Luciano for his final conclusion, and thank you all very much, M8, La Sapienza in particular, and Francesca Bocchini, who has worked from our side to organizing all this, for this very interesting discussion, which is just the beginning of the discussion, I think. So we will continue on. Thank you very much.
So thank you very much, Rossella, for chairing so well this webinar. Many thanks to the speakers for the excellent, very interesting presentations. I apologize again for the technical problem. I would like to thank Marco in Rome and Luisa, Frederique, and Alida in Berlin for the prompt technical assistance to update the link. I saw many colleagues in the end managed to connect anyway, so this is good. So really, this webinar was really excellent. So we're looking forward to continuing this discussion on this topic and other topics related to migrant and refugee health. Please stay tuned on the webpage of the M8 Alliance. There is always an update on the next sessions that we are going to organize. So I hope to see all the other participants that were joining us today in another event soon. So thank you again. All the best. Have a good evening.